बिस्मिल्लाहिर्रहमानिर्रहीम बिस्मिल्लाहिर्रहमानिर्रहीम Rahman allama al-Quran khalaqal insana allama al-bayan. Today I am going to share with you a few of the MCQs. So question 1 is: a 7-year-old male presents to the pediatric emergency department with a 2 days history of cola colored urine and periorbital edema that is most prominent in the morning. His mother notes he had a crusting skin infection on his shins 3 weeks ago that resolved without antibiotics. On examination, his blood pressure is 135 by 90 mm of mercury, which is greater than 99th percentile for age or height. Urine analysis revealed dysmorphic red blood cells, RBC cast, and 2 plus proteinuria. Which of the following longitudinal serological patterns is most characteristics of this condition? Choices are: option A, persistent depression of C3 and C4 levels beyond 12 weeks, early depression of C3 with normalization typically occurring within 6 to 8 weeks. Option C is isolated low C4 levels with normal C3 throughout the clinical course. Option D is normal C3 levels at onset with a delayed drop during the recovery phase. Option E is simultaneous elevation of C3 and C5b-9 membrane attack complex. Question number 2. An 8-year-old girl is hospitalized for management of ASPGN following a recent episode of exudative pharyngitis. She is currently experiencing significant oliguria. Urine output is less than 0.5 ml per kg per hour and has developed basilar crackles on lung auscultation and an S3 gallop. Her serum potassium is 5.8 milliequivalent and her creatinine is 1.4 milligram per deciliter, which are elevated for her age. Which pharmacological intervention is considered the first line therapy for her hypertension and edema? So the choices are: spironolactone to counteract secondary hyperaldosteronism, enalapril to inhibit the renin-angiotensin-aldosterone system, loop diuretics such as furosemide to address volume expansion, propranolol to reduce cardiac output and renal release, hydrochlorothiazide to target the distal convoluted tubule. Question 3 is: a 6-year-old child is diagnosed with ASPGN. Which of the following statements correctly distinguishes the latent period associated with different nephrogenic strains of group A beta hemolytic streptococcus? A. Pharyngeal infection have a longer latent period every 21 days than pyoderma every 10 days. Skin infections, impetigo or pyoderma, typically have longer latent period average 21 days than pharyngeal infections average 10 days. Both pharyngeal and skin infections share an identical latent period of exactly 14 days. The latent period is eliminated if the child receives appropriate penicillin therapy during initial infection. A latent period of less than 4 days is most suggestive of AP, acute post-streptococcal glomerulonephritis, following a skin infection. Question 4 is: in a pediatric patient with suspected post-streptococcal glomerulonephritis, a renal biopsy is performed. Because of atypical features including rapidly rising creatinine and gross hematuria persisting for over 4 weeks, light microscopy reveals diffuse endocapillary proliferation with numerous neutrophils, exudatory appearance. Immunofluorescence shows a characteristic starry sky pattern of IgG and C3 deposition. When examining the tissue via electron microscopy, the pathologist looks for the pathognomonic lesions of the disease. Which of the following best describes the location and appearance of this lesion? This question is a little bit of difficult, but it can come. So option A is subendothelial tram-tag appearance due to basement membrane splitting. Option B is diffuse thinning of the glomerular basement membrane. Option C is large dome-shaped subepithelial humps representing immune complex deposits. Option D is linear deposition of immunoglobulin G along with the entire length of the GBM. Option E is intramembranous dense deposit within the lamina densa. So question 5 is: a 10-year-old girl with a confirmed diagnosis of APSG is being monitored at the outpatient clinic. Her gross hematuria resolved after 1 week and her blood pressure has returned to the 50th percentile without medication. Her parents are concerned about the long-term prognosis and the possibility of chronic kidney disease. When counseling the family on the typical clinical recovery and long-term outlook for pediatric acute post-streptococcal glomerulonephritis, which of the following is most accurate information to provide? Over 50% of children will develop chronic renal failure within a decade. Microscopic hematuria usually resolves within 2 weeks of the initial presentations. Number C is proteinuria must resolve within 48 hours for a favorable prognosis. And option D is the prognosis is excellent with a greater than 95% of children achieving complete recovery. Option E is recurrence of APSG after a second streptococcal infection is highly common. So now you write your answers, and to check your answers, I'm giving you the answers and with the possible explanations. So answer A is B. Acute post-streptococcal glomerulonephritis is characterized by the activation of the alternative complement pathway. This results in a significant depressed C3 levels at presentation, while C4 levels usually remain normal. A hallmark of this infection is that C3 levels return to normal within 6 to 8 weeks. Persistently of low C3 beyond 12 weeks should prompt consideration of other diagnoses like membranoproliferative glomerulonephritis or systemic lupus erythematosus. Answer 2 is C. The hypertension acute post-streptococcal glomerulonephritis is primarily volume dependent due to the primary retention of sodium and water at the distal nephron. Consequently, the RAS is typically suppressed, making AC inhibitors less effective initially. Loop diuretic furosemide are the treatment of choice because they directly address the underlying fluid overload and are effective even with a reduced GFR. Answer 3 is option B. There is a distinctive difference in timing. Postpharyngeal usually manifests 1 to 2 weeks, average 10 days after the sore throat, whereas a post-integumentary skin acute post-streptococcal glomerulonephritis takes longer to develop, typically 3 to 6 weeks, average 21 days. Unlike rheumatic fever, treating the initial streptococcal infection with antibiotics does not reliably prevent the development of acute post-streptococcal glomerulonephritis. Option C. Answer 4 is C. The characteristic electron microscope finding in acute post-streptococcal glomerulonephritis is the presence of large, discrete subepithelial humps. These represent the accumulation of immune complexes between the epithelial cells, podocyte, and the glomerular basement membrane. Option A and E refer to MPGN, and option D refers to Goodpasture syndrome. So answer 5 is D. Pediatric acute post-streptococcal glomerulonephritis has an excellent prognosis, with the vast majority of children greater than 95% recovering completely with supportive care. While gross hematuria resolves quickly, macroscopic hematuria can persist for up to 1 to 2 years without signifying a poor prognosis. Recurrences are extremely rare because the immune response is specific to the nephrogenic strain encountered. So thank you very much for listening, and you can give me your feedback on my WhatsApp number and also via messages. And I wish you all the best and pray that may Allah be our helper, protector and guide. Allah Hafiz.